Hello, everyone, and welcome to today's one-hour webinar, part of Medila's QI webinar series. Today, we'll explore achieving secretory activation with Dr. Paul Meier. Dr. Paula Meier, forgive me for that. Dr. Meier's presentation, Pumping Should Mirror the Infant, Optimizing Mammary Gland Stimulation and Milk Removal During the Early Postpartum Period of NICU Moms, aims to provide valuable insights and practical strategies you can utilize in your practice. Before we get started, I would like to go over a few items so you know how to participate in today's event. You've joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane, and the dial-in information will be displayed. You can submit your text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect them and address them during the Q&A session at the end of today's presentation. Today's webinar will be recorded and made available on Medila University and Medila's Education for Lactation Professionals YouTube channel. There is a handout available, so please be sure to download it before the end of the live event. You can locate that in the attachments in the Go To panel. Click on that link and a new window will open for you. I would now like to introduce Dr. Paula Meier. Paula Meier, PhD, RN, is a professor of pediatrics and nursing at Rush University Medical Center in Chicago. With a career spanning nearly 5 decades, Dr. Meier has made significant contributions to the field of human milk lactation and breastfeeding as a practitioner, researcher, and educator, particularly for premature infants and their mothers. Dr. Meier's continuous advocacy, research, and mentorship have led to an indelible mark on the lactation field. Her legacy continues to inspire and shape the future of neonatal care. Dr. Meier?
Thank you. It is truly a pleasure to be here with everyone today. I haven't had the opportunity to do a webinar in some time, and I have so much new information. My only challenge is making sure I can get through it all. So I'm excited to get started. So first of all, I just want to display the disclosures. The top bullet points that you see are all of our funded research projects that are either ongoing right now that I'm involved in, or we have recently completed. And then I have industry research funding, and I also do consultation and education for Medila, as you see here. And I also want to acknowledge that all of my photos are shown with permission and that they are not to be copied. So what do we want to do today? I have 3 overarching goals. The main thing that we want to focus on is characterizing the importance of evidence-based pumping behaviors during the early postpartum period for NICU mothers. Within that goal, we're going to start by summarizing the biology of secretory differentiation, secretory activation, and coming to volume, which we define as achieving 500 milliliters of milk, of pumped milk daily as a minimum. We're going to describe the intricate interplay between infant suckling and milk removal processes and how they relate to this biology with implications for optimal breast pump use. And finally, we're going to talk a bit about point of care instruments and measures to guide and monitor secretory activation and achievement of coming to volume. And for those of you who are familiar with my presentations, they don't really go like 1, 2, 3, but I have a lot of overlapping with respect to these specific objectives going back and forth with each other. So let's start with the first one. So I want to take you down a little bit of a history as to how I and my team became interested in this topic and how our research has informed where we are today. And I think these are helpful arguments as you focus on articulating the need for additional resources or the need for certain types of supports that you may not have available to you in your practice. So in 2008, we were funded, or I was PI on a grant that focused on looking at the health outcomes and cost of mother's own milk feeding for very low birth weight infants. This was an NIH grant, and we've got many, many publications out of this, but the primary takeaway is that high dose mother's own milk through to NICU discharge reduces the risk for short and long-term health and neurodevelopmental problems and their costs. Our relationship for all of these different complications was dose dependent, meaning the higher the amount of mother's own milk the babies received through the NICU hospitalization, the greater the risk reduction and the greater the cost reduction or the cost savings. Now, this was a cohort of 430 infants. But what we found was we studied the mothers of those babies. And this is what we call our Love Mom cohort moms or mothers. The mothers were not a part of the original grant, but Dr. Aloka Patel, one of my mentees and a co-investigator on the original NIH grant for the infants, wrote and was funded for a smaller grant that focused on looking at the data we had collected from the mothers in this cohort. And there were 415 sets of usable data. So what we found when we looked at the mothers was that our high initiation rates, so we saw a 98% initiation rate in the original cohort. Only 6 infants over that 5-year grant did not receive some mother's own milk. But what we found was what many of you have seen is that those high initiation rates don't translate into the receipt of mother's own milk at NICU discharge. So our data set for this, the work with the mothers, included pumping logs and weekly measurement of what the mothers' feeding goals were for their babies at NICU discharge. So each week the mothers completed a questionnaire. This is what I want to do when my baby goes home from the NICU. So what we found was in the early postpartum period, basically all of the mothers upped their goals from either not wanting to have any mother's own milk and just use formula or partially feed mother's own milk. We saw a major change. All of the mothers decided they wanted to feed their babies exclusive human milk. But as you can see here, what happened over the course of the NICU hospital stay, and what we have here, just so you can kind of take a peek, is our Hispanic moms are in green, the white moms are in pink, and our African American moms, or our Black moms, are in turquoise. And what we saw was not only a decrease in mother's own milk for all of our infants, but we saw there was a disparity with our Black mothers, especially likely to not continue providing milk through to the time of NICU discharge. So what you see here are some of the papers that describe Dr. Patel's work and the focus on some of the outcomes with respect to the racial and ethnic disparity, as well as explanations for this potential decrease in the rate of mother's own milk at NICU discharge. So what I want you to take away from this is we also then studied the Love Mom cohort moms. So as we pondered Dr. Patel's studies, we began to think about, okay, well, what do we do to mitigate this? Because we're seeing mothers that start off, almost everyone provided milk. And we had very high amounts of mother's own milk fed for that first month post-birth. But after that, we began to see decreases, and especially disparities with our Black versus non-Black population. So this is where our research went 2 directions. One was to focus on behavioral and economic interventions, and the other was to understand the biology of early milk synthesis and secretion. So this is the body of work that I led, and this is the body of work that Drs. Patel and Johnson, who were my mentors or mentees in our earlier work, led. So right now they are or I guess the term now is multi-PIs on 2 NIH grants. And the protocol that they are focused on is summarized in this publication. I mention it because it is very innovative, and I know there's probably interest among the group of you. This is an economic intervention. So mothers are randomized to either receive standard care or to receive an economic intervention, which includes the use of a hospital-grade electric breast pump that they can take home with them with no cost whatsoever, pickup of the milk in the home so that they don't have to worry with transportation being an issue, which was one of the things we found was a barrier in our earlier work. And the mothers receive a payment of an opportunity cost for providing milk for their babies, equivalent to 2 hours each day at homemaker wages in Chicago. So that trial is ongoing. And then as a result of that, we also have a follow-up grant, which is the one you see second, which focuses on looking at neurodevelopmental outcomes and growth as a function of the randomized trial. So I'm going to leave that behind. And this is what I want to focus on now, because our work from this Love Mom cohort focused with work from Dr. Rebecca Hoban, who at the time was with us at Rush and is now at Children's Hospital in Seattle. But Dr. Hoban looked at some of the data we had collected from Love Mom moms, of the 415 of them, and did these two really important publications based on those data. And what we found was that in the early postpartum period, our moms' goals for exclusive mother's own milk provision at NICU discharge were very high, and we saw no racial disparity whatsoever. But closer to NICU discharge, those goals remained unchanged, but mothers were unlikely to achieve them. So in other words, they still wanted to provide exclusive milk, but they didn't have enough milk to do so. And that's when we began to see the Black, non-Black disparity, although the decline was for all mothers. So that was the paper that we see here, which was measuring the mother's goals. So what we were able to say from that is lack of mother's own milk at NICU discharge isn't due to the mothers changing their goals or not having motivation. It was something else. So Dr. Hoban's second paper, again, focused on all of the pumping logs that we had for those mothers. And it's where we found that this first 14 days postpartum represented a critical window because it predicted mother's own milk at discharge. So among the 415 mothers that were a part of this study, the primary predictor of mother's own milk at discharge for the very low birth weight babies was whether the mothers achieved coming to volume, or that 500 milliliters of milk, by postpartum day 14. In fact, it was so strong that the odds ratios were 9, and our next odds ratio was something like 2. So we had definitely shown that that was the primary predictor. So that took us to say, okay, this first 14 days post-birth, let's look at the biology of this. So it took us through a body of work that began with looking at the feasibility and the utility of collecting daily mother's own milk samples to measure biomarkers of secretory activation. And I'm going to discuss those a little bit more later for those of you who aren't familiar, but I've spoken about those and written about them, so hopefully people are. But it basically is a point of care test that we need just a drop or two of milk. And our goal for this was to develop normal ranges and identify mothers at risk that fell outside of those ranges. The second was, once we had done that, and we basically have done that, was to look at the relationship between pumping behaviors. Now, pumping behaviors I refer to as timing. So the timing of the first pumping, the frequency of pumping, total minutes of pumping, and the interval, the time between pumping duration. So our interest was looking at pumping behaviors that I just mentioned and mother's own milk biomarkers of secretory activation and pumped mother's own milk volume. So in other words, what is the relationship to pumping behaviors predict? Which pumping behaviors predict achievement of secretory activation and pumped milk volume? Thirdly, we want to focus, and we're in the process of working on this, we have some preliminary data, is to characterize the impact of maternal health complications on the timing and achievement of secretory activation. And finally, is to develop specific pumping strategies that optimize achievement of secretory activation and coming to volume for breast pump dependent mothers with babies in the NICU. So we basically have finished number 1. We've published on number 2. We're focusing right now on these. So that kind of sets the stage in my mind with how we got to where we are, and that if we're going to have milk at discharge, we have to include what happens early post-birth. So of those different focus bullet points that I mentioned, these are the different publications that our team has published based on the topic of secretory activation and coming to volume, using objective measures. So in other words, we're measuring point of care mother's own milk biomarkers to be able to understand what is involved in the achievement of secretory activation, and weighed measures of coming to volume, so weighed mother's milk volumes to achieve coming to volume. So these are the different papers that we've done thus far. And as we go through, I'm going to talk about a couple of these studies because I know they'll be very interesting. They have a lot of clinical application so that we can use those as we move forward. So let's start with what happens in this 14-day window. So first of all, we have pre-birth, which really falls a little outside the 14 days, but this is when secretory differentiation occurs. Then the mother gives birth. When the mother gives birth and the placenta is delivered, the placenta is really, the delivery of the placenta is the trigger for the release of the inhibition on prolactin. So if we look at this graph, what we see here in blue is prolactin concentration, in red is progesterone concentration. So with the birth of the placenta, the progesterone plummets because the progesterone is no longer being produced by the placenta. So by day of life 1, 2, 3, we see this rapid decrease in progesterone. That allows high concentrations of prolactin that are already circulating to begin to catalyze the synthesis of milk. So this happens between days 1 and 2. Under this hormonal milieu, the mother goes into achievement of secretory activation, which, as we look at the term literature, occurs sometime between postpartum day 2 and 3, with anything after 72 hours being classified as delayed onset of secretory activation. Then over the next week and a half, 2 weeks, what we see is the mother's switching to a different milk regulatory process that is autocrine controlled and achieving 500 milliliters of milk a day. And that is the primary predictor of having milk at NICU discharge. So that's what happens in this critical 14-day window that we began to take apart and study. So first of all, let's look at what happens in secretory differentiation. What we know is that there's a growth in the number of secretory cells. We see ductal branching, but what we don't have is we don't have milk synthesis because prolactin that catalyzes the synthesis is held in check by high circulating concentrations of progesterone that are secreted by the placenta. We also know that secretory differentiation may be affected by inflammatory and metabolic morbidities that cause changes or perhaps impairments in some of the ductal and growth of the secretory cells. Then the mother gives birth, and that placenta delivery triggers secretory activation, as we said, by removing progesterone. Now, secretory activation that we think of as milk coming in, lactogenesis 2, is a very complicated process that involves the upregulation of 4 transcellular pathways that synthesize the components that go into making milk. It involves as well 1 paracellular pathway closure. And when I say one, it's one type of paracellular pathway throughout the whole gland closes. And we do know that during this phase that appropriate stimulation by the infant or the pump is really important. Now, a role about secretory differentiation, as I had mentioned before, our work with animals shows that inflammatory processes, especially as studied with overweight and obesity, in the mammary gland during pregnancy affect gene expression for prolactin signaling as well as receptors. We know that many NICU mothers have metabolic complications, and that could be one of the possible risks that we see when mothers give birth, and what we think might be delayed or impaired secretory activation could really be some underlying problem with secretory differentiation as a consequence of these complications that the mothers are more likely to have when they have babies in the NICU. So our question then is, what can we do about that? If the mothers do experience impairments in secretory differentiation, can we mitigate those with effective post-birth milk removal strategies? And we don't know, but this is one of the interesting areas because, as many of you know, our mothers get sicker and sicker and have more and more risk factors that could potentially impair processes that are involved in secretory differentiation. Now let's break apart what we know about birth to secretory activation. So we know that the placenta is delivered, that causes the progesterone to plummet, releases the prolactin, and that the typical mother is going to achieve secretory activation between day 2 and 3. Well, one of the things that we know, in addition to potentially causing problems that would be structural, is we know that when mothers are overweight and obese, that adipose tissue harbors progesterone. So those are mothers that are likely, whether or not they have babies in NICU, to have a delayed secretory activation because the progesterone falls more slowly. We also know that retained placental fragments that continue to secrete progesterone can impair lactation. It's the same mechanism. And it's also the same mechanism that we're concerned about for those of us that are concerned about the use of early hormonal contraception, which is an exogenous progesterone that's going into the mother's body at the time that progesterone should be decreasing. So that's the mechanism that we are always concerned about. We also know this is affected by pumping frequency. It's likely affected by ineffective pumping, as I would call it. In other words, the pressures aren't correct, the breast shield doesn't fit, the breast shield isn't placed correctly, the mother has an inferior breast pump. And as well, it can be affected by other comorbidities that really mask disordered secretory differentiation that appear as secretory activation. So if we take a minute and look at what happens, what we see is on day 1, the studies show us that a healthy full-term baby removes 15 milliliters of colostrum by feeding approximately 10.2 times in the first 24 hours and averages 1.5 milliliters per feeding. But as I always say, it's like saying then a miracle occurs, because by day 4 to 7, a healthy mother is producing between 500 and 600 milliliters of milk. Well, what are the mechanisms involved in this? Well, this is one of the important slides, and I'm going to take a little longer time to explain it because of the fact that it is the underlying biology for the use of point of care measures of secretory activation. So it's what is happening in the breast. So in the breast, these are the individual cells that make milk. Okay? This is how they appear at birth, and this is how they appear at the completion of secretory activation. So what you see here in the individual cells is that they are beginning to secrete components that we would call through the transcellular pathways, meaning that they're produced in the cell and transferred, one of those being lactose. Okay. But what is happening during this period of time in pink is that the paracellular pathways between these individual milk-making cells are wide open. And then what happens under the influence of prolactin and under the influence of infant suckling is that those paracellular pathways begin to close. It's a gradual process, but it's what distinguishes birth from secretory activation achievement. Secretory activation achievement must have the closure of the paracellular pathways. Now, why is that? Well, that is because lactose is the primary osmotic driver of milk volume. And with the open paracellular pathways, even though the cells produce lactose, because of its osmotic gradient, it goes right back into the maternal circulation and is excreted in the urine. So you can actually measure urinary lactose over time, and it's as good as point of care measures of mother's own milk that we use. It's just a lot less convenient for mothers to have to measure their urine for 24 hours, but you could do that. So the closure of the lumen is this distinctive part, because then it allows lactose to stay in the gland. It brings in all of the extra liquid that is responsible for what we call a mother's own milk volume. Well, I talked about the fact that we could measure urinary lactose. We could also measure biomarkers of mother's own milk using lactose, but it's a lot more complicated. So what we use instead is sodium, because sodium is the opposite of lactose. What happens with sodium with open paracellular spaces is that it comes from the mother's circulation into the milk itself. So early milk, the early colostrum mothers make is very high sodium. And then as the paracellular pathways close, what happens is the cells still secrete sodium chloride into the milk, but there isn't any additional coming through an open paracellular pathway. So the mother's own milk biomarker that we choose to measure is sodium, because sodium can be done point of care with just a drop of milk, and you have your result in a matter of minutes. So this is really the biology, and this is really complicated when you think about it because of the numbers of things that can slow this process down or impair it completely. Probably the most modifiable for all of this is the stimulation of the mammary gland. So this is just kind of looking at, if you want to know more about the biology of secretory activation, this is a paper by PhD student who's now a postdoctoral fellow at the University of Utah, wrote as a part of her dissertation work. And it's a figure that shows nicely what we're measuring with point of care is sodium. And sodium, because of the fact it crosses from the mother's circulation into the milk, is very, very high in early milk. But over the course of secretory activation, as the paracellular pathways close, it decreases and then it levels off until sodium again would be high in mastitis, because the paracellular pathways open. It would be high as mothers begin to wean. Many of you talk about the fact, if you're in lactation, that babies notice when mothers are weaning or they've had mastitis, they don't like to drink the milk from that breast because it does taste different. So that is the issue with the sodium. Sodium is easily measured point of care. And when I say mother's own milk biomarker, that's what we're measuring. So what does the infant do? We often don't appreciate the role of the infant as a part of this secretory activation. We think of the breast, but what is the stimulation that's happening? Well, if we take a peek at the baby in this early post-birth period, this baby was 17 hours old. Watch how this baby sucks. It's very rapid, intermittent sucking. So he'll suck like this for a little bit, and then he just rests. The mother thought he was asleep and not interested. And then he rests. Okay, this is a uniquely human sucking rate and rhythm. And babies use this. You almost would look and think the baby was on a pacifier. Babies use this because they don't have to swallow. Babies are using this because the baby at most is getting a milliliter of colostrum during this feeding. So the baby doesn't have to swallow. He can suck very rapidly. So that is the mechanism that takes us from from birth to secretory activation. Now let's look. Once the paracellular pathways are closed and we see the upregulation of all the milk components, the next thing that happens is what we call this building, or this incredible increase in milk volume in the mammary gland. So it's going from secretory activation to 500 milliliters of milk a day. So this is really a critical time because the mechanism for continued lactation has changed completely. Now each breast operates separately, which is important to ensure that the milk is getting removed equally from both breasts. And it's the concept that the milk must be removed to be replenished. So that's what we call effective. as much of the available milk is removed as possible over this period of time. Over this period of time as well, the alveolar membrane is so sensitive to milk stasis and downregulates prolactin very quickly as a consequence of milk stasis. So there are two mechanisms that regulate milk synthesis over this period of time. The first is called the suckling-induced prolactin surge, and it's illustrated so beautifully in this classic graphic that was published in 1983. That hasn't been changed, it's still relevant. So this shows very, very nicely what happens. This is time after onset of suckling. So time 0 is when the mother would sit down to suckle the baby or use the pump. And what we see then is the combination of the sucking stimulus and the milk removal causes this rapid surge in prolactin. So that's why we call it the suckling-induced surge, to 2 to 3 times its resting baseline value over the course of 35 to 40 minutes. And then gradually it will return to the baseline, which is why frequent stimulation is essential, because over the course of a day, what you get is 5, 6, 8 of these. And the only time that prolactin is released to be able to stimulate milk synthesis is when there is milk removal and stimulation of the gland. This is not the same as skin to skin. It's not the same as thinking about your baby. It is actual suckling and milk removal. Now, this is just another example from another study that looks at this baseline versus peak prolactin. And I want you to take a look at this, because this is the mechanism for sustaining lactation through to weaning, is that the prolactin is released when the mother removes milk, or the baby removes milk from the mother. But if you look at the pre, which is the lighter color rectangle, if you look at the histogram across here, what we see is not only just the baseline prolactin decreases over time, but so does the peak prolactin. But the time that it is the most pronounced, as you can see, the difference as well as the peak values are in very, very early lactation. So this is for a reason. This is meant to be so that mothers will be able to make this transition from secretory activation to coming to volume effectively, but it is dependent upon milk removal and stimulation to the gland. The second mechanism is we used to call the feedback inhibitor of lactation, but it's a little more complicated if we look at the more recent science. And it's the autocrine-paracrine regulation of the unremoved milk. So that what it means is when milk is left behind in the breast, there are all of these different local factors. Remember, I told you it was autocrine, so it's not hormonal as much anymore, it's autocrine. All of these local factors that influence whether the milk is going to be replenished, and we will see continued milk secretion. So it's a very complicated mechanism. We know it as supply and demand. It's the mechanism for weaning. But what I want to call your mind to, especially if you don't work routinely in the NICU, is that when breast pump dependent mothers either don't pump frequently enough or pump ineffectively. Now, when I call ineffectively or inefficiently, that can be the mother that really needs a hospital grade electric breast pump, but is told she has to manage with a hand pump that works sequentially as opposed to simultaneously to remove milk. That could be the mother that's not using the right pressures. It could be the mother that is pumping but doesn't have the right size breast shield that she should have. So all of those things result in leaving milk behind. So a mother can begin weaning in this period of time inadvertently. She doesn't know that's what she's doing. And I think that that explains a lot of not just pump dependent moms, but a lot of mothers that really get caught during this change to the autocrine and paracrine regulation, is that the mechanism for lactation regulation changes. And if the mothers aren't aware of that and able to function either with their breastfeeding or their pumping, it's a time with really great risk for early unplanned weaning. Okay, so what does the baby do during this time? Well, we all know what this baby does. He changes the sucking. So this is a baby first going to breast. You'll see him using the stimulation to get the milk flowing. And then over the course of that, you'll see him changing to a slower suck. He's changing to a slower suck because he has to swallow. So here in the beginning, okay, this is what we would call that stimulation phase, if you think of it even on the breast pump. And then the milk begins to flow. You can watch him. He starts sucking more slowly because he has to swallow. Okay, he's swallowing. And that is the change in the rates that we see is really very infant driven. The infant is going to change the sucking rate and rhythm based on milk flow, because if there's high flow, the baby has to swallow. And then this swallowing and the change in sucking that occurs with that swallowing is what constitutes effective milk removal. Because if the baby were feeding like the baby I showed you earlier, and that's all the baby did, that isn't effective milk removal. Okay, so I've gone through the biology. Now I want to focus on describing this intricate interplay between the infant suckling and milk removal. Now, I did this a bit just now by showing you the videos because I spent some time thinking, should I show you the videos under this goal or under the one before? But I wanted to put them where they made the most sense to me. But now let's look at this interplay. So many people think, well, you know, the whole idea of mother's own milk removal is just a way of marketing a breast pump. All breast pumps are the same. All pumping techniques are the same. It's just, or hand expression is just as good. So my work in this field really goes back to 2005 when I actually wrote a letter to the editor for Journal of Human Lactation, which some of you may find interesting and want to pull up, focusing on how it's important that industry do its own trials of products as opposed to having them funded by the taxpayers. But our work really began with trying to make breastfeeding, or I guess I would say milk removal, more comfortable, effective, efficient, and convenient for mothers who have to use the breast pump 24 hours a day, 7 days a week for weeks and months. And I'm sure for those of you who've worked in this space, the hardest part when people don't work with this population is having them understand it's not using the breast pump a couple of times a day. And then while you're at work, and then you go home and you have a full-term healthy baby to feed. So the idea that you have a pump that has to replace the infant to do everything the infant does. And what I've realized over the course of my career is having to explain what does the infant do so that we can try to then mimic what the pump does to fit what the infant does. Because for the mothers who are pump dependent, the pump is their baby. So let's start with just the most common sense thing possible. So it's what happens with milk removal? Well, most of the time we think about milk removal as getting the milk out. The important thing is getting the milk out. We can get more milk out with this or more milk out with that. And that isn't really the only role. Getting the milk out really needs to be species specific in a way, because milk removal doesn't just assure adequate intake. Milk removal, by what I've just shown you with the autocrine and paracrine control of lactation, is critical to regulating continued milk synthesis and secretion. So we can't just look at what gets the milk out. We have to look at, is it as close as possible to the baby over time so that we can have regulation of lactation, especially as we move into this autocrine and paracrine control. Although even during secretory activation, we see a very specific role for the infant suckling to be able to stimulate this process. So just a couple of examples here about milk removal and the pump-dependent NICU mom. I've talked for years about the idea of 2 milk volume targets, and I've explained this over and over to mothers and to staff, because there's a mismatch between what the baby needs. So if we look at this diagram, it's a perfect way of explaining it. Milk removal is critical to milk synthesis and secretion because it assures the baby gets enough milk, But the baby you see here is going to be fine on about 100 milliliters of milk a day at the end of 2 weeks, if that. But the mother needs to make at least 500 milliliters of milk a day to regulate this process. So this is what I call the mismatch. I still find that it's not well understood even by NICU nurses and people that should know in NICU that don't. And it's often not understood by people that are outside the NICU. People always think, well, the mother will make as much as the baby needs. Yes, and then 2 or 3 weeks later, she has no milk. So there are many, many documents, this education sheet being one, in the Provide Compendium. As I've mentioned in my previous webinars, this set of materials is free of charge. It's available. Mothers can download it. People can download it, share it with mothers, but it explains the critical nature of this first 2 weeks, as well as 2 milk volume targets. Now, I couldn't leave this without showing this particular one because I know not everybody works with NICU babies. But this is a perfect example of the late preterm and early term infant. When those babies are simply fed at the breast, and we know that their milk removal is ineffective. They don't wake to feed, they fall asleep early in the feeding, they slip off the nipple, they appear satiated, and everybody's happy because at least they've been at the breast, but they've not taken enough milk. And then over time, even if we supplement this, if the mother isn't pumping in this critical window, what we have is 2 weeks later, the baby wakes up and is ready to eat, but there's no milk. So this is, I think, a good example of the late preterm and early term babies that don't come to NICU. Okay, so summary. Now, this is a complicated slide, but I'm going to go through primary things. So if we look at this whole process of going from secretory activation to coming to volume, then secretory differentiation to activation, and then activation to coming to volume. Let's look at what goes on in the breast with the baby and with the pump. Now, this should be a summary. So we've talked about the fact that this is hormonal. It's the fall in progesterone that triggers the prolactin. We see an upregulation of 4 transcellular pathways and a closure of 1. Okay, that's the first 2-3 days in a healthy mom and baby. But what happens then in the second path? We switch to an autocrine control of lactation. Prolactin is released only when the infant or the pump use suction and milk removal, and it doesn't include skin-to-skin holding or other non-feeding stimuli. What does the baby do during this time? Well, the baby times the sucking rate and rhythm and the frequency to the fact that there's little available milk. So the baby suckles very frequently, uses a very rapid suction pattern because there's not milk to swallow. And this pattern is thought to program the increase in the number of secretory cells and prolactin receptors in the mammary gland. And I would say for clinical purposes, most mother-baby units provide some type of routine assessment to be sure everything is going well for the baby who's breastfeeding, at least to check the latch and appropriate suckling. Okay, let's look at this next phase. So we see, once again, I showed you the video, the sucking rate, rhythm, and suction pressures adapt. There's now more milk available, so the baby changes those. We see longer intersuck intervals because the baby has to swallow boluses of milk. So we see a slower sucking rate. And mother's own milk removal, if we're studying it, is characterized by effectiveness, meaning the baby gets enough milk out, efficiency, that the baby does it in a timely manner, and comfort. And comfort, of course, means that it doesn't hurt. Okay, so now let's look at, we've got the breast, we got the baby, this is what's normal. What does a pump do? Well, we know that during secretory differentiation, that the initiation pattern in the breast pump was created specifically to mimic this uniquely human sucking rate and rhythm. And I worked with Medela engineers to bring that pattern to market after testing it in 105 mothers of babies in the NICU. We know as well that there are multiple risk factors in this population that we have to watch for. And I would say that personalized pumping assessment, like we would do for a mother and baby, breastfeeding is not routine. Then we go to this coming to secretory activation to coming to volume. We changed the breast pump suction pattern because that mirrors what the baby does. And if we're going to evaluate the pump has to be evaluated based on what the baby does. Is the sucking effective, efficient, and comfortable? And this is where so many assessments fall short. We don't do that. We hand a mother a pump and say, have at it. So our solution to this, I want to show you here, is a new work that I just finished along with Leslie Parker at University of Florida that's called My Personal Pumping Pathways. And the pumping pathways have been developed so that there is one pumping pathway, which is a personalization and a standardization through to secretory activation achievement. And then the second pumping pathway is a pumping assessment over the period of secretory activation to coming to volume. We're excited with these. We have several studies underway. We have a quality improvement group working with Medela underway with these as well. And we'll be doing a full webinar on these on September 24th. And I hear the link is in today's chat, and it will be at 1 o'clock as well. So finally, let's talk a little bit about point of care measures. I've talked about the sodium. I want to share with you as we talk about these measures, the study that we just published a couple of months ago or so in Journal of Perinatology. And it was a study that we worked on for some time along with my PhD student. It was her dissertation work as well. And it was the first study to incorporate objective measures for all of the variables of interest. So we didn't have to rely on mothers recording anything. So we have pumping behaviors, pumped milk volume, and achievement of secretory activation, all measured with objective measures. And I don't think I have another photo of the sodium probe anywhere, so I'm going to show it to you here. This is the sodium probe, and you just put a drop of milk on it, and you get the value of the sodium. This is actually the potassium one, but the sodium one is yellow. Okay, so this study was a 14-day observational study to measure the biology of secretory activation and coming to volume in breast pump dependent mothers. We enrolled 35 mothers, and we have 29 fully usable data sets, which is pretty amazing given this study. The mothers used an adapted smart pump for all pumpings in this 14-day period. They had one pump dedicated to the mother-baby unit when they were hospitalized in the maternity stay, one for the NICU, and one to take home. Our measures included daily mother's own milk biomarkers of sodium, breast photos and scans, and maternal descriptions of breast changes. And I'm going to just talk today about the biomarkers. So first of all, the pump. So Medela adapted this pump with our input to be able to completely automate pumping recording. So we don't need pumping logs anymore. So the pump itself has a data logger that allows the mothers to, in real time, we know whether the mother's pumping or not pumping. So basically that tells us how many times a day she pumps, how many minutes she pumps, and the inter-pump intervals. We worked with Medela to develop this customized app that allows the mothers to weigh their milk separately for the right and left breast that was embedded in this scale. And all of it connected into the data logger, so it recorded the pumping behavior as well as the milk removed from each breast separately. So I want to just go through the quick findings. These have been published, so I'm going to go just through findings and what the takeaway important things. So our time-dependent changes, we looked over time. So all of these are from day 1 through day 14, and this is for the 29 mothers as a whole. So we found that over the first several days, mothers increased the daily minutes they pumped. They increased the daily number of pumpings as they pumped. And they also, unfortunately, increased the longest interval between pumping as they pumped. So then we looked, the purpose of the study was to characterize pumping behavior. So we looked at mothers that we called high intensity and low intensity pumping groups. So what we found was that the mothers clustered into cluster A that were our high intensity, and our cluster B that were low intensity pumpers. So you can see here again the same data over the course of 14 days. Our mothers that were high intensity pumpers pumped significantly more minutes. They pumped significantly more times than the other mothers, and they had shorter intervals between pumping. In other words, they didn't go as long between pumping. Now, these were all very, very highly correlated, as you can imagine, for the two groups, because daily minutes is totally related to number of pumpings and to longest interval. But what we found was the greatest predictor was the number of daily pumpings. So this tells us that pumping is a primary modifiable factor for the achievement of secretory activation. So in cluster A, basically all mothers but one achieved secretory activation, and in cluster B, only 58% of mothers did. So this is looking at the sodiums that would characterize secretory activation. And what we see is that the mothers in red had significantly greater achievement of secretory activation with lower concentrations of sodium. But what we found as well in this population, which I think is extremely important to take away, is that the mean postpartum day for achievement of secretory activation was 5.8. It wasn't 2 to 3, which I think is important for mothers to realize if they're still making small volumes of milk over a period of time, this is normal. We did not have a mother achieve secretory activation prior to postpartum day 4. That was the earliest. And of the mothers who did achieve secretory activation, over half reversed it at least once during the first 14 days. And that was due to irregular pumping behaviors. We found that each additional hour spent pumping during the first 5 days yielded an additional 1,278 milliliters of milk over the first 7 days. So let me restate that because it's almost unbelievable, but we've gone through it with every statistician and over. For each additional hour spent pumping in the first 5 days, resulted in an additional 1,278 milliliters of cumulative milk volume over the first 7 days. So pumping is huge. We also then began to think the critical window. So is this critical window 7 or is it 14 days? Because if you look here, what you see in our pumping clusters, looking at daily milk volume, is that we saw increases in milk volume and we saw decreases in sodium all the way through to day 7 or 8 in this population. And then after that, we really didn't see changes. So our thinking began, okay, well, do we rethink this? Is it 7 days or 14 days? Well, it's consistent with this for the 7-day window that we saw in Dr. Medina Polena's paper with her overweight and obesity mothers. Because what we found in this particular study, this was looking at daily rate of change in pumped milk volume. And we saw that the mothers that had a BMI of 27 or over had a much slower rate of pumped milk volume over the first 7 days. Their increase was about 33.1 milliliters per day, whereas the mothers that were normal BMI had an increase each day that was about 65.8 milliliters. So we saw almost twice the difference, and then we had marked differences in terms of milk volume at the end of that 7-day period. But the mothers didn't change after that. And the same with secretory activation achievement. So what we saw was that 7 days is when we saw the changes, and then after that, we didn't. So I'm not saying at this point that day 7 is the norm, especially since I think we've got a lot of variability, especially with maternal risk factors. But what I can tell you is achievement of coming to volume and milk at NICU discharge is a 5.8 days, not 2 to 3 days. Each additional hour spent pumping increased the odds of achieving secretory activation and significant increases in milk volume. I'm going to introduce this because I think that once you get beyond the 2 weeks and you've got that period of time through discharge, what we decided we were going to do was to use the questionnaire that we used in our maternal goals study and use it clinically. And we put into place my feeding goal when my baby goes home. And what we did was a touch base with the mother each week to look at her milk volume and whether it was going to be compatible with her goal at the time of NICU discharge. So in summary, I'm going to just kind of quickly go through these. We have to prioritize lactation resources during this period. It is when we have limited resources, this is when it's the most important. The Provide compendium can be used to guide interventions and QI initiatives. We have to be sure a simple modifiable problem is corrected, and that is that breast pumps are available without delay. Mothers shouldn't share them. They shouldn't have to wait on them. Minimum of 6 hours postpartum, a minimum of 5 pumpings a day, which is what our research has shown. Avoiding hand expression only. And then I think the rest of it is what we've often talked about is the engaging of the families, trying to train our nurse super users so that they're able to do these measures as well. So I'm going to leave you to look at the summary so we can take a question and re-emphasize the fact that my first pumping pathway and my second pumping pathway mirror the biology of lactation and the role of the healthy infant during mammary gland stimulation and milk removal. And we'll do more of this in our webinar on September 24th. So thank you all so much. It's been a wonderful pleasure for me to share this work with you. So hopefully there are some questions.
There definitely are questions, Dr. Meier, and we might only have time for 1 or 2 of them, but we're going to start with the first one.
Okay.
In the summary slide listed under secretory activation CTV, you mentioned prolactin release only with infant pump removal, not skin-to-skin holding or other non-feeding stimuli. The question is, what would be some examples of non-feeding stimuli?
Okay, well, I'm thinking more in terms, it could be skin to skin. People think that if you look at a picture, like I don't know if you've noticed, but there are a lot of things in the literature focus on imagery, like looking at a picture of the baby, looking at, or some type of relaxation techniques have been proposed in the past. And those may very well facilitate milk ejection by oxytocin, but not, and the same thing with skin to skin. But the important thing is that only milk removal and infant suckling or pumping at the breast is going to release prolactin.
Okay, perfect.
That was an easy one.
If there is such a thing. Okay, does it matter how far apart the pumping sessions are as long as you have 8 to 12 times in 24 hours? I have differing opinions.
You know, this, our data, and if you take a peek, the paper that we published in Breastfeeding Medicine that looks at the review of all this work that was published earlier this year, that's an integrative review, really shows that the critical number to reach is 5. So during this 2-week period of time. If you can do more than that, that's great. But the critical number appears to be 5 for achievement of secretory activation and coming to volume. And I almost hesitate to say that because every mother is different. You know, the mother that has lactation risks may very well benefit from more pumping. But what we did as a part of looking at this 5 is to go back into all of the literature. And even though mothers in the studies have been instructed to pump 8 to 12 times, the most we could find in any study was one of the ones that we conducted back in 2008, where mothers pumped on average 6 times. Most of the time it's 4 to 5. And people who have teased out the differences in outcomes, and not just us, but there's a paper, I'm thinking this was at Duke University, I think, teased out, and it's listed in our papers, teased out the fact that getting to 5 was really the critical demarcation with whether the average mother was going to be able to achieve secretory activation. So, so obviously more than that if you can, but I've never read a study where mothers reached 12 times a day. I've never read a study where on average mothers reached 8 times a day. Most mothers, there was a handful of mothers that maybe were outliers, but most of the mothers were even under the 5 times a day.
Okay, and I do think that is all the time we had. You had so much content, which was amazing. So thank you for that. So,
Hopefully not too, but I'll take, if people want to send those questions in, I'll be happy to look at them and answer them for folks.
perfect. We will do that. And thank you again, Dr. Meier, and a warm thank you to everyone attending today's engaging webinar, which is a part of our series QI webinar series. Today's topic, pumping should mirror the infant, optimizing mammary gland stimulation and milk removal during the early postpartum period for NICU moms. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete and provide your feedback. On behalf of Medela and Dr. Meier, thank you so much for joining us today and have a great rest of your day.
Thank you.